stenting of secondary aortic interruption. Conflict of interest, nothing to declare. So going to the history and clinical, 32-year-old female who presented to us with exertional dyspnea, palpitations, and headache for last 2 years. She had a surprisingly unremarkable birth, childhood, and early adulthood, with having undergone uneventful pregnancies. Last delivery had occurred 5 years back. Patient had undergone 2 successful deliveries without any significant complaints during the peripartum period. On examination, her pulse rate was around 100 and BP difference was significant. In upper limb and lower limb, the BP difference was around 40 millimeter of mercury. That was the only clinical finding that we could get out of it. Other than that, faint continuous murmur was there in bilateral scapula. All peripheral pulses were well felt. That was also a surprising thing in this patient. So considering the BP difference and her symptoms, we ordered a CT aortogram. CT aortogram showed 3D reconstruction was also done, which clearly showed that there was a juxtaductal critical coarctation of aorta with extensive collaterals from the subclavian artery. Other than that, echo showed a concentric LVH, LV systolic function was normal. There was mild mitral regurgitation and bicuspid aortic valve was there. However, there was no significant aortic stenosis or regurgitation. And considering the juxtaductal coarctation, we considered going for the percutaneous intervention. So this classification, Siluria and pattern classification, is mainly for neonates who present with interrupted aortic artery, aortic arch. However, the most common one here, as shown here in this figure, it is the isthmus around A. That is the most commonest one, around 15 to 20% patients present with the typical coarctation or interruption at this site. Our patient had the similar finding, and we considered going for the passing the wire through either femoral or subclavian route. We had taken both the accesses, 6 French femoral artery and 6 French left radial artery access were taken. And first we tried to approach through the femoral artery. As you can see that we tried to approach with the JR guide and with coronary wire, but we couldn't negotiate the lesion. So after that, we tried through the subclavian artery. So this is the subclavian angiogram. And after that, we first tried to negotiate the lesion with pilot wire. Pilot 50 and pilot 100 were used, but we couldn't negotiate the wire. And after that, along with the single marker small balloon, the lesion could be crossed with cross-it 100 wire. So you can see here that there is a single marker small 1 millimeter balloon. Along with that, we could cross the lesion. And after crossing the lesion, here is the actually most important finding, where the JR was crossed along with the balloon assistance. A 2 millimeter balloon was used for tracking the JR because the lesion was very tight. It was almost as if the fibrous band was there. And along with the balloon assistance, we crossed the JR catheter. After that, snaring was done from the femoral root. And after that, with a view to implantation of stent, we exchanged the guide wire with a safari from the femoral root. And after that, since we had a very good support with the safari wire, we used a graft stent and completed a successful intervention. So for this, we had used the Bentley B graft. Previously, there are a number of reports published in which all of the operators had used the usual conventional brown covered graft stent. So reason behind that is we had used a 16 by 38 millimeter graft stent, which goes through 11 French. So the reason behind that is that there is a low chances of foreshortening. That it has a high radial force compared to the usual conventional brown stent, and it is made up of cobalt chromium stent and covered with a 200 micrometer EPTFE tubing. However, in the HICC stent, that is a usual brown stent, it has a gold covering and the radial force is not that great. However, there is no head-to-head comparison. but this is probably the first time we have used a covered aortic intervention with the such a Bentley stent. So as you can see that optimized lesion care with a wide range of diameters and lengths are available and easily customizable. Those are the advantages. Coming to the usual surgical versus interventional debate. So usually in last 10 to 15 years, there is a paradigm shift in the management of this isolated interrupted aortic arch in adulthood. There was a paper that was published in 2019 in Current Problems in Cardiology. They talked about it, that percutaneous interventions can easily be done compared to the surgical interventions. Previously, a number of case reports have been published in JACC as well as in CCI. One from India, which has been published from the Jaydeva Institute in Bangalore. They had done the similar stenting. However, all those operators have used the usual brown stent. So from this case, our take-home message is that complex anatomy of interruption or coarctation is usually encountered in adult patients as well. The techniques that can be used, there are different techniques you have to use to outmaneuver these lesions. Use of a covered stent made the procedure safer by protecting against aortic rupture. However, there is still a small chance of obstruction of branch vessels, as well as there is a chance of ischemia and endoleaks. The patient is in our follow-up for last 1 year. However, we have not encountered any ischemia or endoleaks in this patient yet. Along with that, knowledge of the strength and limitations of the hardware is equally important. And the use of coronary intervention skills in treating this structural heart disease is shown here, that we used a balloon-assisted crossing of the guide wire, along with that a balloon-assisted tracking of the guide. Both were used in coronary stenting that we have used in a structural intervention successfully. Thank you.